Let's start talking about root morphology. It gets more exciting, my friends. What are the functions of roots? Why do we have them? They offer a system of support or anchorage for the teeth. They afford a sensory system to warn of threats to the teeth. Okay, hot, cold, too much pressure, decay. They provide reparative methods to respond to pathology, pressure, trauma, or movement, as well as they house the nourishment system of the tooth. Remember that pulp chamber. So let's take a look at some of the sensory functions. The nerves of the tooth can be stimulated when a stimulus is carried from the root surface through the dentinal tubules to the nerve tissue. Root decay, root resorption, abrasion exposes those dentinal tubules, and that can result in pain, the pain response. Rubbing the root surface with an instrument can also elicit a pain response. And what are we doing as dental hygienists? We're rubbing the root surface with an instrument. These roots can be very sensitive. So the cementum that covers the dentin has bare areas. It's thin and it's rough, okay? And when it's exposed, those dentinal tubules are exposed, and those tubules transmit sensation. So let's take a look at this root surface here. All right, this is an enamel pearl. Remember what an enamel pearl was? That, excuse me, it's got a, I'm trying to find something, never mind. Anyway, it's a misplaced clump of enamel blasts. So you've got your central nerve chamber here, okay? You've got it lined in odontoblasts. These are your dentinal tubules that go out to the outer surface of the cementum. And when that cementum is worn away, these tubules are exposed, which allow for the transmission of sensation. This has two root canals on it. You've got your main root canal coming to a foramen, which is a hole, a foramen, where everything enters and exits. And then this one has an accessory canal or a lateral canal. So if a tooth is having a root canal, for example, and the dentist is only filling this one and doesn't see that there's this accessory canal, that oftentimes is one of the main reasons why root canals fail. The patient still gets an abscess. That type of thing is because there are these accessory or lateral canals that can't be found. We're getting better and better with technology. Now endodontists, the root canal specialists, are using microscopes and other things to aid in finding these accessory canals. But if the pulpal tissue becomes inflamed, then hot or cold stimulation is going to cause pain. If a nerve is active but badly inflamed, a cold stimulus can also cause pain. The longer the response takes to subside, the more damaged the pulpal tissue. So you have a patient who's calling and says, I have a toothache, and the receptionist or whoever's answering the phone, the appointment coordinator is asking questions to try and rule out things. What makes it throb? Okay, are you waking up at night with it, or is it a cold sensitivity, a hot sensitivity when you touch or bite sensitivity? Does it go away when you stop applying the hot or cold or your fingernail right against the gum line area? They're trying to get a background on what's going on, because the longer the response takes to subside, the more damaged the pulpal tissue. Pulp only knows one sensation: pain. That's it. So if gases are present within the pulpal tissue, say when the pulp is infected or necrotic, these gases expand. And the problem is the root inside doesn't expand. So once affected, the gases expand, they put pressure on both sides of the nerve tissue, right, that remain vital. Those expanded gases then force themselves out of the root apex into the surrounding bone and periodontal ligament. Because your tooth isn't going to expand, the gas has to go someplace, right? So it's going to go out. Pressure and temperature responses are not elicited by the pulp tissue. Pressure and temperature are not responses from the pulp tissue. The nerve tissue within the bone, gums, and periodontal ligament elicits those responses, because we've got that hammocking, our PDLs, we have nerve tissues, we've got our gum tissue, we have everything surrounding the root, which allows our body to interpret what we're feeling. Okay, so the root canal tissues do not have nerves that can stimulate the feeling of temperature or pressure. The root canals can only respond to pain. How many times has that been said? You think that's going to be a question? Yes. So we've got reparative and nourishment functions of the roots as well. We had sensory, now we're talking about the reparative and nourishment functions. And within the root canal, there are arteries, veins, lymph tissue that nourish the tooth from the inside. And these vessels enter and exit through that orifice at the apex, which is called the apical foramen. It's a hole at the apex. They allow nutrients and oxygen to circulate throughout the pulp chamber, as well as remove harmful products and carbon dioxide from the tooth. So if the flow of these vessels is restricted, the nerves and other tissues inside the pulp chamber could die of anoxia, lack of oxygen. And inside the tooth, you've got these odontoblasts. Okay, blasts are forming cells that allow secondary and reparative dentin to be formed in response to trauma. This process is not restricted to the root, but to the entire pulp chamber. Remember, you have on the outside of the root, you have your cellular cementum on the apical third, but we're talking on the inside of the root now. It's lined in odontoblasts. The apical third of the root at or near the apex can continue to form cementum on the outside of the root. If this continues to the extreme, it's called hypercementosis. Osis, O-S-I-S, is the condition of cement, hyper, too much, cementosis. All right, and it forms a cementoma at the apex of the root. A cementoma is usually associated with bone destruction or trauma. If the cementum is different from this cementum, the cementum for the cementoma is different from the cementum that lines the rest of the root. So first, it can continue to grow and add onto itself. Now we're talking about that cellular cementum. Then in this process of adding onto itself, the cells are trapped in the cementum. Okay, so the cementum is called cellular cementum because it can continue to grow. So the support functions of the root, the shape and length of the roots have a direct effect on how much anchorage and support they can afford. Remember when we were talking about the teeth, the maxillary anterior teeth were triangular in shape. The root surfaces were triangular versus the mandibular anterior are more oval. So the longer and wider the root, the more support it receives because it has more surface area for the ligaments to support it. The longer the root, the more firmly embedded in the bone it is. Common sense. The greater the surface area of the root, the more PDL fibers, the periodontal ligament fibers, can attach to the root and to the bone. So a tooth with multiple roots has its periodontal ligaments dispersed in all sorts of different directions versus a single rooted tooth. The concavities and grooves on the root also allow for more surface area and for more periodontal ligaments to attach to at different angles. So that's why teeth have the grooves. The roots have grooves to give more surface area for more periodontal ligaments. The roots with triangular cross section offer resistance to lateral displacement. Curved roots afford resistance to occlusal, apical, and distal forces. And the multiple periodontal fiber directions in the furcation areas between the roots give the tooth direct resistance to occlusal displacement. So these PDLs are all trying to hold the tooth in place. The resistance a tooth can withstand is influenced by the width, shape, length, curvature, and the number of roots. So we've got two pictures here, A and B. Okay, it's actually the same tooth. This is a deciduous molar, a maxillary deciduous molar. Look how wide spread apart those roots are. And they're spread apart so wide because this is where the premolar, the permanent premolar, is housed in here. So the crown is going to be here. And as the tooth, the premolar, tries to erupt, it's going to dissolve through resorption processes, these roots. And once the roots are resolved, the tooth is going to fall out. So if you've seen baby teeth that have fallen out, very rarely do they have much root. Look how curvy these teeth are compared to the maxillary permanent teeth. Very curvy. They have a pinched in waist. They have big height of contour here, widespread roots. This is a deciduous molar versus a permanent molar. So the PDL, or periodontal ligament, is composed of collagenous fibers of connective tissue. The periodontal ligaments are connective tissue, and it's capable of being tensed and compressed. It's got some stretching and compressing capabilities similar to elastic. The pressure exerted on the tooth compresses the PDL on one side and tenses it on the other. So one side gets stretched and another one gets shrunk a little bit. A small movement is called mobility. Our teeth are not ankylosed. We have this microscopic movement to help displace the forces of chewing. And a slight amount of mobility is healthy and it's normal. Now, we don't always see this, okay? We can see a little bit of wiggling on the mandibular anterior, for example, on the incisors, but we really don't see it anywhere else. When the external force is strong enough to exert pressure on the bone, it triggers resorption within the alveolar bone. And that is from the osteoclasts, which dissolve bone in the area of the pressure. So when enough bone is resorbed, the pressure ceases and stops, then the periodontal ligament can regain its normal width and the tooth moves away from the external force and into the newly remodeled bone. So what are we talking about here? Tooth movement, the opposite side of the tooth, okay, the periodontal ligament is tensed. You've got osteoblasts that form bone in response to the tension to form the new bone. So you've got force on one side that is creating osteoclasts on the other side. The tooth is going to move in this direction. Once that force stops, osteoblasts are going to fill in the bone. Pressure and tension remodel the bone. The result is that the tooth moves away from the external force into the new location. And this exactly, my friends, is what orthodontic movement is all about. The orthodontic movement, they exert pressure on one side of the tooth, that's the force, which then that sustained force causes the tooth to move gradually into the desired new location as that bone is being dissolved. And while during that retainer phase, everything's being remodeled. So only a slight amount of movement is possible during a specific amount of time. Otherwise, other things can be happening like root resorption. There could be some detrimental effects if teeth are moved too rapidly. So for orthodontics, the tooth must be held in a fixed new location long enough for those collagenous fibers of the periodontal ligament to remodel. Otherwise, that residual tension of the fibers causes the tooth to move back. And then you've got relapse. And you all know, if you've had kids that have had orthodontic treatment or patients or whatever, they don't like wearing their retainers, the retainer phase. So oftentimes there's relapse. Our teeth want to go back to where they were. They have memory. So if the pressure is too extreme, bone and root can be resorbed, and the same cells that resorb bone can also resorb the root. If a tooth has no occlusal antagonist, doesn't have a tooth that it bites with, the tooth wants to continue to erupt with supereruption. That tooth then moves mesially if it doesn't have another tooth next to it. That's the mesial drift we've talked about. And the shape of the roots and that residual tension within that periodontal ligament can play some part in causing that mesial drift phenomenon. So, this is all about root surfaces. The grooves and depression of the roots make these areas harder to clean for the patient and more susceptible to periodontal disease. Canines and premolars have longitudinal grooves and depressions, but these areas seem easier to clean than the mesial roots of the molars because they're more anterior. Patients can get to them. We can reach them better when we're doing our scaling. Molars are not only farther back in the mouth and harder to reach, but the roots are wider on the buccal than they are on the lingual, and they're harder to gain access to in the middle of those root areas. We just can't get to them effectively, no matter how good we are. So, some of the greatest periodontal problems come from furcation involvement. Furcation is the point where those multi-rooted teeth separate their roots. Maxillary premolars and occasionally mandibular canines may have a bifurcation where the buccal and lingual roots divide. Maxillary premolars usually do. It's an anomaly, but sometimes mandibular canines can be bifurcated. Don't see that very often. Maxillary molars have a trifurcation because they have 3 roots. Mandibular molars have a bifurcation because they have 2 roots. And again, furcations are hard to keep clean and usually result in severe periodontal problems. So when you're doing your periodontal assessment and your probing and all of your charting, and then you have to make a determination based on your assessment information, you have to come up with a prognosis for periodontal disease, future periodontal disease. What is their likelihood of getting more disease in the future? If you've got a furcation area, they have a poor prognosis, which means they've got a high rate of periodontal disease coming back. Maxillary versus mandibular. These are first molars. The roots are widely spread apart. Look at the root trunk. This is the root trunk here and here. Okay, the root trunk is a depression that is going into the furcation. The furcation is not until you start getting into the roof of the root or the crotch of the root. There's a lot of different terms for this. And then the root trunk, depending on how long that root trunk is, will also determine how much bone can be lost before you have a true furcation problem. The outer surfaces of the roots are rougher than the enamel covering the roots. This makes hygiene more difficult as well because it's harder to clean the biofilm, the plaque, the calculus, and other debris from exposed root surfaces, whether it's exposed in the mouth with visible recession or that invisible recession through bone loss. So the gum could be in the same area at the CEJ, but you've got a pocket where the bone has apically migrated. Anterior teeth usually have one large root canal per tooth. So we're talking about the canals. I'm not going to make you memorize these canals. The mandibular canine sometimes has two canals. Remember that mandibular canine can sometimes be bifurcated. But when it's got two canals, the mesial is going to be larger than the distal. The nerves and blood vessels enter and leave through the apex of the root. Sometimes more than one opening is evident. One is the main apical foramen and the others are accessory or lateral foramens. So this is the main foramen here, and you can see this is the accessory canal. And look at this. I love how textbooks do this. You've learned about traditional film, and they have a little dot, a bump, dimple, or pimple. Where is this supposed to be? When you take it, it's supposed to be on the incisal occlusal area down here. Number one, for your landmarks, if it's all down here, but number two, what happens if this identification mark is obscuring something that's going on there? We don't know. So we want it out of what we're trying to take a look at. Look at the different root canal foramens. Wide variety, all the same tooth. Whenever a root has two apical openings, they are each smaller than if the root just had one opening. If a tooth has two root canals in the same root, they are each smaller, okay? They're each smaller. The maxillary first molar has three roots, and each root has at least one canal. The mesiobuccal root oftentimes has two canals, which each of which is smaller than the other two roots. Lower mandibular premolars usually have one canal, and maxillary premolars can have two canals. Again, I'm not making you memorize this. This is something that dentists need to know. What I'm going to be more interested in you knowing is the shape of the roots, because that's where your instruments need to go. The maxillary first premolar may have two canals because guess what? They got two roots. Mandibular molars have two canals, a mesial and a distal. The mesial canal is usually wider than the distal because the mesial root is bigger and wider and longer. The mandibular first molar is the most likely tooth to have two canals in the mesial root, again, because it's a bigger root. When the mesial root has two canals, there's a buccal and a lingual canal. And again, the take home is both are smaller than if you had one opening. Okay, if you've got two openings going down the same root, those openings are going to be smaller than if you had one big opening. It's all that same. Second molars usually have a mesial and a distal root canal, okay, because they've got a mesial and distal root. The lower third molars, again, third molars, anything can go. It can have 1, 2, 3, or more canals. Maxillary molars usually have 3 because they've got 3 roots. The first molar is more likely to have 4 canals, again with that mesial buccal root, which is the longest and the fattest of all the 3 roots, are going to maybe have 2 canals. One canal. This is that maxillary first premolar that's bifurcated. Remember that groove that goes over the mesial marginal ridge and can go all the way up the root? Look at the shape of this interproximal area here. You need to remember that when you're scaling so you can roll your instrument, the toe of your instrument in here to clean this groove. And a lot of hygienists just go straight here. They forget about this, so there's always oftentimes residual black calculus there. But this is what I want you to take away by the end of this course is the shape of these roots. This is that lingual tilt on the mandibular first premolar. Can you see how it looks like it's tilting towards the lingual versus the second premolar? It's a little more straight up and down. First molar, roots are widely spread apart. That palatal or lingual root is straight up and down. Second molar, the roots are closer together. The palatal root is slightly angled towards the distal. Three cusps on the buccal, 1, 2, 3. All right. That wasn't so bad, was it?
No.
Okay. No. All right, I'm going to stop the recording now. Are there any questions?